Right, 2 minutes after the hour, so I'll go ahead and get started. Hello, everyone, and welcome to the Neurocritical Care Society Pharmacy Section Journal Club webcast. My name is Abdallah Ammar. I'm a neurocritical care pharmacist at Yale New Haven Hospital, and I'm one of the moderators for today's session. We have other two moderators online, include Dr. Karen Berger from New York Presbyterian Hospital and Dr. Mohammed Effendi from the Capitol Health Regional Medical Center. We're excited to present two articles for you today, but before we get started, please take a moment and make sure that your mics are muted. At the end of each presentation, there will be a Q&A session, so feel free to post your questions in the chat, or you can unmute yourself at the end of the session and ask the presenters your questions directly. You can also follow us online on Twitter using the Twitter handle NCSPharmacyJC. Now I would like to introduce our speakers. Our first speaker is Dr. Bernice Lee. Dr. Bernice, she is a PGY2 Critical Care Pharmacy resident at Yale New Haven Hospital, and she will be presenting an article with the title of Fluid Balance and Outcome in Critically Ill Patients with Traumatic Brain Injury, the CENTER TBI and OCENTER TBI study that was published last August in Lancet of Neurology. Now I'll turn things to our first presenter.
Just to confirm, you can see my slides?
Yes, we can. We can hear you well.
Awesome. Sounds good. So I'll get started. Thank you, everyone, for joining. As Abdallah or Dr. Ammar has said, I'll be presenting on fluid balance and outcomes in critically ill patients with traumatic brain injury, a prospective multi-center comparative effectiveness study. So for a quick background, about 288,000 hospitalizations every year for traumatic brain injury, and each year, about 80,000 to 90,000 people experience the onset of lifelong or long-term disabilities. So patients present in various forms, from mild alterations of consciousness to comatose state and death, and a lot of these patients can range, or injuries can range from intracranial hemorrhage to ischemia to hematomas and etc. So with TBIs, these patients have a very wide variety of injuries, and these can range significantly from mild to severe. Mortality rates generally is about 50,000 deaths annually, and so here it does have very significant morbidity and mortality impacts on these patients. And treatments vary extensively depending on the severity of injury. So treatments that vary depends on these patients and the extent of the injury, and does become very patient specific. So we monitor these patients or assess these patients using the Glasgow Coma Scale, which ranges from 3 to 15, 3 being the worst and 15 being the best. And we look at eye response, verbal response, and motor responses. We would get an imaging for these patients. Generally, CT scan is our gold standard to assess the injury assess the patients and assess the extent of the injury and where the injury has occurred. You could also consider getting an MRI for these patients, but it does take a little bit longer than CT scan, so generally the CT scan is the first choice for these patients. So focusing more on that fluid aspect, the goal of fluid therapy is to optimize the circulatory system to ensure adequate cerebral blood flow and oxygenation. So why is this important, especially for the brain-injured, critically ill patients? So fluid tonicity is more pertinent in these patients. Tissue edema may impair cerebral blood flow, and optimizing cerebral blood flow with fluid management becomes more challenging. This is because hemostasis in these patients are disrupted, and there's a lot of there could be loss in these fluids in the critically ill, from maybe potential third spacing to hypermetabolic states to just a fluid and blood loss for these patients. So the cerebral blood vessels may dilate due to the injury, ischemia, hypercarbia, and hypoxemia, and etc. And the capillaries in the brain may also become more permeable, which allows more fluid to leak in and out. So these patients, what happens is when there's an increase in blood pressure, the cerebral perfusion pressure increases to help maintain that cerebral blood flow to the brain. But with that, including the more leaky vessels, as well as more vasodilation in the vessels in the brain, it can actually cause more cerebral edema as well. So maintaining that balance becomes more difficult for these patients. So what is the preferred fluid for resuscitation? Comparing sodium or normal saline versus lactated ringers, normal saline is preferred because it has a higher concentration of sodium, 154 MEQs per liter, compared to lactated ringers, which is about 130 MEQs per liter. And the osmolarity is just higher in normal saline compared to lactated ringers. All of this comes into play with the osmolality and the tonicity for these patients, the fluid shift risk. Comparing saline versus albumin, there was that study, the SAFE-TBI study, that showed that albumin was associated with higher mortality rates. So overall, the recommended fluid or preferred fluid for these patients is normal saline. So going into a little bit more of this autoregulation curve, in normal circumstances in patients who are not injured, we fall on this blue line. As you can see, there's that plateau area generally between the maps of 60 to 170, which the cerebral blood flow is able to be maintained pretty steadily during that range. This is because the vessels in the brain is able to constrict and dilate to help maintain that adequate cerebral blood flow. What happens in these patients who have brain injury, the line becomes more linear, as you can see with the red line here. So more or small adjustments in blood pressure or mean arterial pressure has more significant impact in that cerebral blood flow. So in the lower side, it would cause hypoperfusion and potential ischemia in these patients. And more on the higher side, it would cause hyperperfusion, but could also increase that intracranial pressure in the brain. Looking more at the more fluid aspect, once that fluid is administered, it affects the tonicity. The tonicity is the osmotic pressure gradient. And generally, in normal circumstances, we're able to maintain the osmolarity similarly between the brain and the vasculature outside of the brain to prevent that excess fluid shift. What happens in these brain-injured patients is that you have that disruption in that blood-brain barrier, which decreases the ability to maintain the electrolytes, fluid balance, and solutes, and it becomes more sensitive to the changes to that pressure and more dependent on that pressure difference. Other aspects also to consider is the cerebrospinal fluid circulation and volume, inflammation, autoregulation, venous impedance, and systemic circulation. All of these play a role in the cerebral blood flow and oxygenation. Ultimately, can also impact the cerebral edema as well. So as I mentioned before, maintaining that adequate fluid balance is very essential for these patients. So management has shifted from more of a dehydration strategy to normal volemia and mild hypervolemia. In the Brain Trauma Foundation guidelines, previous versions have stated or recommended euvolemia by adequate fluid replacement and a cerebral perfusion pressure of greater than 70 millimeters of mercury with fluids and or vasopressors. However, with that target, it was found that these patients have some more systemic side effects, such as more increased risk of acute respiratory distress syndrome, and also has found that these patients with these targets were found to have more positive fluid balances because we were giving them more fluid. In more of the recent versions of the Brain Trauma Foundation guidelines, so the 2007 and the 2016 versions, they've actually removed the fluid recommendations due to the absence of the high quality evidence. In 2018, the European Society of Intensive Care Medicine suggested to aim for more normal volemia and avoid that restrictive fluid therapy in these patients. Looking at some of the previous studies available, a study by Clifton et al. Looked at the fluid thresholds and outcomes from severe brain injury. This was a retrospective analysis of a prospective randomized multicenter study that assessed intracranial pressure, mean arterial pressure, and cerebral perfusion pressure, as well as fluid balance, 96 hours after randomization. So in this study, they included about 392 patients with severe non-penetrating brain injuries, and they defined the severity with a GCS of 3 to 8. So they found that within this study, that exceeding the thresholds of ICP, so greater than 22, MAP of less than 70, cerebral perfusion pressure less than 60, and a more negative fluid balance may be associated with worse outcomes in severe brain injury patients. They also found that fluid status itself, more negative balance of about negative 600 mL, was also independently associated with an adverse effect on outcomes. Again, another study by Moore et al. This looked at the impact of fluid balance on intracranial pressure in patients with TBI, and this was a retrospective analysis, which they monitored the ICP for 7 days or more and included trauma patients, 100 adult trauma patients. They had monitored the fluid balance from days 3 to 7, and they looked at more of that positive versus negative fluid balance. They found that more positive fluid balance was associated with higher intracranial pressure in these patients. And lastly, the study by Zhao et al. Was an analysis of the association of fluid balance and short-term outcome in traumatic brain injury. This was also a retrospective cohort study, which they included 351 patients, and they monitored fluid balance and intracranial pressure for 7 days, and they looked at short-term outcomes, which was improvement and deterioration based on GSCS scores. They found that the upper fluid balance, so more positive, about 3.5 liters, was associated with higher incidences of AKI, increased days in neurocritical care units, and increased intracranial pressure. Overall, with the study, they found that lower fluid balance, about less than 600 mLs, and upper fluid balance, so greater than 3.5 liters, were associated with poor short-term outcomes and intracranial pressure variation. Upper fluid balance was also found that it may be an independent predictor of poor 30-day clinical outcomes as well. So for our rationale for the study, fluid therapy is very essential in critically ill patients with TBI. Fluid restrictions could have adverse consequences, where fluid overload can cause systemic complications, brain edema, and increased intracranial pressure. Current practice guidelines for fluid management in TBI patients still remain controversial. So the goal of the study is to quantify the variability in fluid management policies for patients with traumatic brain injury and study the association between fluid therapy and outcomes. The study design incorporated the Centre TBI, which was a collaborative European neurotrauma effectiveness research and traumatic brain injury study. This included 63 centers across Europe and Israel from December 2014 to December 2017. And they also included the Oz-Enter TBI study, which was incorporated 2 major studies in Australia from February 2015 to March 2017. Both of these studies was a multi-center longitudinal prospective observational cohort study. So they included patients of 16 years of age and older, and those admitted to the ICU within 24 hours of injury. It was interesting that I'll also mention a little bit later that majority of the patients were not included in the study or excluded due to this inclusion criteria. Diagnosis of brain injury with head CT, and of course informed consent. Exclusion criteria included severe pre-existing neurological disorder, but what was interesting is they did not actually explicitly state which kind of neurological disorders they excluded, and this information was also not available in the supplemental material. So procedure-wise, they define mean daily fluid balance by input minus the output. Input included IV fluids, renal replacement therapy fluids, enteral fluids, as well as any blood products that they have received. Output included urine output, enteral losses, and etc. One thing that they did not include was the insensible losses. Mean cumulative fluid input they looked at on days 1 through 7, 10, 14, 21, and day 26. So outcomes, association of fluid balance and input with ICU mortality and functional outcomes at 6 months. Primary outcomes, they looked at ICU mortality, which was more acute outcomes, and the Glasgow Outcome Scale extended at 6 months. This GOSE was an interview or a survey that the patients filled out or was conducted to assess the outcomes for these patients. They defined worst outcomes as a GOSE score less than 5. Some of the safety outcomes they looked at was respiratory failure, ventilated-associated pneumonia, duration of ICU stay, and mortality at 6 months. Some of the statistical analysis they used was ANOVA for comparison of continuous variables, chi-square test for categorical variables, linear mixed effects model to assess variations in fluid management, and a two-sided p-value of 0.05, which they considered statistically significant. Looking at some of the results, initially in the center TBI study, over 4,000 patients were enrolled, but about 2,371 patients were excluded because they were not admitted to the ICU within 24 hours. So about 2,138 patients in that study was admitted to the ICU. In the Oz-Enter TBI study, they included 198 patients that were enrolled, and 1 patient was excluded from that study. Overall, about 2,125 patients were eligible for analysis for the study. Looking at some of the baseline characteristics, some notable differences was age between the two groups. So there was a higher age, median age, in the more positive fluid balance compared to the lower fluid balance. And for female-wise, there was more females in the more positive fluid balance compared to the lower fluid balance. What was interesting was that there was only about 24 to 28% of females in the study. The majority of the patients were males in the study. History, there was no difference in history of cardiovascular disease, use of anticoagulants, and use of antiplatelets between the two groups. And GCS at baseline, there was no difference between the two groups. Looking at the different components of GCS, it's separated by mild, moderate, and severe. About 50% of the patients were actually classified as severe GCS, followed by mild and then moderate. So majority of these patients had pretty severe baseline characteristics when they came in. Some other notable differences was hypotension before admission, higher incidence in the more positive fluid balance, and epidural hematoma was higher incidence or more common in the lower fluid balance. There was no difference in hypoxia before admission, major extracranial injury, and Marshall CT classification. Of note, with this classification, about 46 to 50% of patients was classified as CT classification of 2. Looking at some of the treatments, vasopressor use during ICU stay, use of colloids, hypertonic saline, and mannitol was higher in the more positive fluid balance compared to the lower fluid balance and shows a statistical significant difference. And renal replacement therapy was no significant difference between the two groups. Looking at some of the clinical parameters, median of mean cerebral perfusion pressure during ICU stay, there was a lower CPP in the more positive fluid balance, and they showed a statistical significant difference. And median of mean sodium during ICU stay showed no difference between the two groups. Looking at some of the primary outcomes, in ICU mortality, there's statistical significant difference between the two groups, whereas a higher incidence of ICU mortality and more of that positive fluid balance. And looking at the unfavorable outcome at 6 months, which again is defined as GOSE less than 5, it was a higher incidence again in the more positive fluid balance than the negative. I've also included these values or the primary outcomes adjusted for different components and possible confounding aspects, including GCS, hemoglobin status, etc., and showed similar results as the ones that were unadjusted. I've also included some of the secondary analysis. So the studies, the values were also adjusted for mean cerebral perfusion pressure and mean sodium, and again showed similar results as the ones that were not adjusted with these components. So looking at some of the complications and outcomes, there was a statistical significant difference in respiratory failure, higher incidences in the more positive fluid balance, as well as mortality at 6 months, higher incidence again in the more positive fluid balance. There was no differences associated with ventilator-associated pneumonia and duration of ICU stay. So looking at the efficacy outcomes, you can see in this graph here that dotted line is when the mean daily fluid balance is 0 or euvolemia for these patients. And as you can see at that point, the graph is the lowest point, which indicates the better outcomes. Higher on that y-axis, higher the number, the worse the outcomes. So as you can see here, that once these patients have that more positive fluid balance, the graph goes up, which indicates more worse outcomes based on GOSE. And again, similarly on the more negative fluid balance, it does show the graph going a little bit higher, which indicates more worse outcomes, but not to as much extent as the positive fluid balance. Here I've included the scatter plot, which indicates just the center-specific mean fluid balance between the different institutions. And you can see here that there's a very significant variability between like the institution and the target fluid balance for these patients. This really highlights how the guidelines don't recommend a strong recommendation of what the target value is and what current practice is going on at the moment. So for the author's conclusion, in critically ill traumatic brain injury patients, more positive fluid balances were associated with worse outcomes, and the study suggests aiming for more of that neutral fluid balance. So going into some of the strengths of this study that I've noted is that this was a very large prospective multi-center study that included over 2,000 patients total. It assessed the current practice. Like I mentioned before in that scatter plot, it really shows like the current practice, how different institutions target different fluid balances, and really shows that external validity of this study. This was also controlled for measured confounders or potential measured confounders and showed similar results as those that was not adjusted and was able to show that statistical significant difference in the primary outcomes. Lastly, this was the randomized group was overall very well balanced between the two groups, and both groups were equally represented. Baseline characteristics, there are some notable differences, but majority of the baseline characteristics are similar between the two groups. Some of the limitations that I've noted included that it did not compare certain physiologic variables that was not captured in these studies. These included central venous pressure, PEEP, fluid intake normalized by body weight, difference between hyperosmolar and maintenance fluids, as well as the amounts of different types of fluids that was received. So this was not separated or collected for this study. It did not account for any insensible fluid balances. So I've noted before, these patients are critically ill and may be more in that hypermetabolic state, maybe losing fluid elsewhere, which can impact the potential, may potentially impact the results. It was also difficult to determine effect of single treatment due to the complexity of TBI condition. So as mentioned in the background, these patients can range from very simple to very complex conditions. So it's very hard to say that fluid balance is the sole reason of potential poor outcomes for these patients. Also, this had more of an observational data aspect, so it was difficult to, or can't say we've completely ruled out or adjusted based off of all the potential confounding factors in the study. Some of the takeaway points included that currently best practice guidelines for fluid management in patients with traumatic brain injury remain controversial. Positive daily mean fluid balances were common and consistently associated with higher ICU mortality and worse functional outcomes. And lastly, further studies need to be conducted to really assess the results of this and potentially make more strong fluid recommendations for these patients. So overall, based off of this study and the available other available literature, targeting a more euvolemic volume status in these patients may be most beneficial. And I want to thank everyone who was able to attend, and I'll open up the floor for any questions at this time.
Thank you so much for your great presentation. I guess I'll start with my first question, which is, at your institution, do you allow hypervolemia or hypovolemia or euvolemia for your traumatic brain injury patients, and why?
Oh yeah, absolutely. So for us, I was looking, we don't actually have specific protocols or guidelines posted for us. However, looking at the practice that we do, we target more of that euvolemia or slightly hypovolemia in these patients and try to avoid that hypervolemia for these patients. So this, of course, to prevent any more potential cerebral edema with that hypervolemic aspect and more decreased cerebral perfusion pressure if we have too negative fluid balance in these patients.
The other thing that always comes up is discussing the tonicity of the solutions that are being administered to the patient instead of the volume we're giving to the patient, especially for traumatic brain injury or general neurological injured patients. Did the authors account for the type of fluids they were giving to their patients in terms of measuring the tonicity or any sodium content of the fluids that are being given to their patients?
Yeah, absolutely. So one of the limitations of the study was actually the potential types of fluids that they gave. They didn't really highlight like the amount of like osmolar fluids as well as like maintenance fluids. That was one of the limitations of the study. However, they did monitor the amount of sodium that was given for these patients and showed that there was no significant difference between the two groups for the sodium content.
I think we have a question in the chat. Did the authors specify how the urine output was measured? And did all the patients have Foley for accurate measures of their urine output?
Absolutely. So they did not specify how urine output was measured. Unfortunately, they did not go into detail on that aspect. I would assume that definitely some of these patients may have had Foleys, but they may have also may be voiding on their own for these patients. But they did not highlight specifically how they collected the urine output for these patients.
And the other thing that you mentioned as well, they didn't measure any sensible losses as well in terms of the output for these patients. All right, any other questions for our speaker? All right, I guess we will switch to our second speaker. Share your screen. So our second speaker for today is Dr. Chelsea Wemsley. Dr. Chelsea is a PGY2 neurology pharmacy resident from Grady Health System, and she will be presenting the second article for today. The title of the article is Second Intravenous Immunoglobulin Dose in Patients with Guillain-Barré Syndrome with Poor Prognosis. That was published last April of this year in Lancet Neurology as well. So we can see your screen if you want to start presenting.
Okay, thank you. Can everybody hear me?
Yes, we can.
Okay, great. Thank you. Thank you for that introduction. So as Dr. Abdallah mentioned, today I'll be discussing the SID-GBS trial with you all. But before we begin, I do have a question for you all to reflect on, or you can respond in the Twitter Journal Club section. So for those of you who have dealt with Guillain-Barré before, we hope and anticipate that the patient will get better after initial treatment with either IVIG or Plex. But what do you do if they don't? So would you give another round of Plex? Would you try IVIG again, maybe switch approaches or do something else? So keep that question in mind throughout the presentation today, and maybe your answer will change. So at this time, I have nothing to disclose. And just a quick overview of what we'll be discussing today. I do want to spend some time, since Guillain-Barré is not a super common disease state, on some background information as well as current treatment approaches before we move into discussing the trial at hand. And then we'll spend some time discussing how to apply the results of this study to clinical practice, as well as some future directions for research. So to begin, Guillain-Barré is an immune-mediated process that affects the peripheral nervous system, and up to 70% of affected patients are able to identify a preceding illness, which is usually an upper respiratory infection or a GI illness that can happen anywhere from 3 days up to 6 weeks prior to the symptom onset of their Guillain-Barré. The most common identified pathogen is Campylobacter, followed by cytomegalovirus. And there's a variety of other viruses and bacteria that can be implicated. And most recently, in April of 2021, there was a neurology systematic review that revealed higher rates of Guillain-Barré in COVID-19 patients. And although Guillain-Barré is commonly thought to be associated with flu vaccines as a whole, it was really first seen with a 1976 swine flu vaccine and hasn't been linked to vaccines in subsequent years. flu vaccines, excuse me. However, in July of this year, the FDA did issue a statement on an increased risk of Guillain-Barré following vaccination, specifically with the Johnson & Johnson COVID vaccine. So Guillain-Barré is a progressive disease state that usually presents as bilateral weakness and numbness that can be characterized by either areflexia or hyporeflexia. There are several variants in which the areas where the disease presents itself can differ, as well as the degree of sensory versus motor involvement. However, the most classic presentation is the sensory motor subtype that starts in the lower limbs and progresses upward over a period of hours to weeks before a plateau is reached. About half of patients will get to their peak weakness or that plateau within 2 weeks. 80% get there within 3 weeks, and then 90%, so the vast majority of patients, by 4 weeks. Most patients do make a full recovery, but this may take up to 3 years or even longer in some cases. There are a variety of complications that can result as a consequence of Guillain-Barré, with respiratory failure being perhaps the most concerning. And then dysautonomia can occur in up to 70% of patients, which may lead to hemodynamic instability as well. So with these two factors in mind, there's many cases that early ICU admission would be recommended to monitor respiratory status and vital signs closely. Venous thromboembolism is also common as a result of these patients being rendered immobile for periods of weeks to months at a time, as well as pressure ulcers. And last but not least, many of these patients are admitted to the hospital or healthcare system for a very long time while they're being diagnosed and treated and recovering from the syndrome, so they can end up with hospital-acquired infections as well. So Guillain-Barré occurs in 1 to 2 per 100,000 persons annually, which translates to about 3,000 to 7,000 cases in the US each year. And it tends to affect men more than women. Around 20 to 30% of patients do have weakness severe enough to require mechanical ventilation, and up to 40% of patients don't respond to initial treatment. Additionally, 20% of patients are still unable to walk independently at 6 months. And mortality can be anywhere between 3 and 7%, a lot of which is due to the complications that we just discussed on the previous slide that are associated with prolonged immobility or hospitalization. So while we might not see these patients often, it is important to know how to manage them appropriately when we do, as the disease state is associated with a significant degree of morbidity. And the goals of our therapeutic interventions are to decrease the amount of time it takes these patients to recover, as well as to decrease their overall length of stay in the healthcare system. So there's 2 main subtypes that have been identified concerning the pathophysiology of Guillain-Barré, and the first being demyelinating disease type, where it's believed that affected persons develop autoantibodies against the myelin sheath around the nerve, and this subtype accounts for the vast majority, around 90% of cases in the United States and Europe. The second subtype is associated with autoantibodies that attack the axon itself and usually spare the myelin sheath. So the axonal subtype is more common in Asia and other parts of the world, and these can be differentiated by performing a nerve conduction study. So our 2 mainstays of treatment are going to be either IVIG or Plex. Both have been shown to decrease time on the ventilator, as well as lead to faster recovery time, although one has not been shown to be better than the other. And in fact, the American Academy of Neurology guidelines don't offer a recommendation for one over the other, although they do comment that Plex may carry a greater risk of side effects and is more difficult to administer. Now, you may note that the guidelines are dated back to 2003, but there really hasn't been a lot of advancements in the management of these patients since then. So these remain our 2 mainstays of treatment. You may also note that corticosteroids are not listed here, as data has shown that these are not helpful in Guillain-Barré, and the guidelines actually do specifically recommend not to use them for these patients. So there was a very informational prospective study published in 2019 that purely observed the treatment trends of 1,300 patients with Guillain-Barré around the world. And you can see that here in the dark blue is IVIG, which is by far the most common treatment. And followed by that is Plex in that sky blue color. And I do want to mention that in the very light blue, particularly in Germany, they use immunoadsorption, which is similar to Plex. However, it selectively removes immunoglobulins while preserving other plasma proteins, which is in this practice isn't currently available in the US. So a little bit about IVIG. It is a pooled blood product that's prepared from the serum between 1,000 to 15,000 healthy donors. And this provides a diverse repertoire of antibody specificities. It primarily consists of IVIG, which I have pictured here to the right, but they also may contain trace amounts of IgM and IgA. The concentration of immunoglobulin in IVIG is at least 3 times higher than regular plasma. Its use can be categorized by immunodeficiency versus immunomodulation therapy, and it was first used in the 1950s to treat people with immunodeficiencies. And this was used at a lower replacement dose of 200 to 400 milligrams per kilogram, given either subcutaneously or IM every 3 weeks. It wasn't really until the 1980s that its potential as an immunomodulatory agent was discovered, with good results in the treatment of ITP. And when it's used as an immunomodulatory agent, it's given intravenously, most frequently at a dose of 2 grams per kilogram spread over the course of several days. And since the 1980s, IVIG has been proven beneficial in a wide variety of both autoimmune and inflammatory disease states. And now over 3/4 of IVIG is given not for immunodeficiencies, but for immunomodulation. So there's no robust data comparing IVIG to placebo in Guillain-Barré, but there is limited evidence from a few open trials in children that suggested IVIG does hasten recovery compared to supportive care alone. And its mechanism is not fully understood, but put simply, you're adding antibodies from healthy people to fight autoantibodies in people with immunologic conditions. However, there is more to it than that. So for instance, the Fab region, which is the upper portion of the Y shape, can both block receptors as well as bind to autoantibodies and neutralize them. The lower tail portion, called the FC region, can also help expand the production of healthy antibodies as well as prevent the further production of autoantibodies. And this region can also bind to complement, which has downstream effects that lead to decreased inflammation. Treatment with IVIG is not without risks. So about 2/3 of patients experience headache. 1/3 of patients develop a fever after the infusion, and more than 10% of patients have some sort of infusion reaction, which may lead to changes in blood pressure or heart rate. Other serious adverse effects include thrombotic events, as well as AKI, particularly with sucrose-containing products, as well as hemolysis. Many of these risks can be mitigated by slowing the rate of infusion, as well as administering the total dose over the course of several days and giving pre-medications. So due to the rapid expansion of potential disease states to treat with IVIG over the past couple of decades and the complex process by which it's made, it's often on shortage, or your facility may receive a certain allotment each month. Additionally, there are a wide variety of different brands, a few of which I've listed here based on what I've personally seen most frequently in my practice. And most brands run between $20,000 and $30,000 based on the average wholesale price for a 70-kilogram patient if you're using it for immunomodulation. So for these reasons, it's important to make sure that the use is appropriate, and this can be difficult since a lot of its use is off-label and used to treat conditions that we're not necessarily used to seeing. So many facilities have introduced either formal or informal stewardship programs in recent years, including rounding to the nearest vial size to prevent waste, or using ideal body weight rather than total body weight or adjusted body weight. And then some institutions I've heard of also cap their doses, for instance, at 100 grams. But at my institution, we have a handful of pharmacists who must approve the use of IVIG before any order can be verified. So if you recall, up to 40% of patients fail initial treatment. So what then? We know that combining the two treatments, so combining IVIG and PLEX, is not useful and not recommended in the guidelines. Many of you may be aware that using PLEX right after a course of IVIG will remove that expensive IVIG that you just gave, unless you wait a period of around 14 days, at which point the nerve damage that happens as a result of Guillain-Barré may already be irreversible. There also was a large randomized controlled trial that showed no benefit with IVIG that was given after PLEX versus either treatment alone. So what about a second dose of IVIG? In that same prospective international study that I mentioned earlier, it was observed that worldwide, 35% of patients with no initial response were retreated. However, rates of retreatment were higher than average in the US, where they observed that nearly half of all non-responders got a second dose of IVIG. So with that in mind, I'm willing to guess that at least half of you listening, when I asked that question initially, would have opted for a second dose of IVIG. And prior to the SID-GBS trial, we really didn't have a lot of data to support that decision. So prior to 2020, there were several case reports of success with a second round of IVIG. However, Verboon and colleagues published a larger prospective observational study last year with very similar inclusion and exclusion criteria to the SID-GBS trial. However, of note, that only 38 of the 237 included patients actually received a second dose of IVIG, but their results suggested that perhaps there was no benefit in repeating IVIG for these patients. So here we are in 2021 with conflicting data and still no strong evidence to guide refractory Guillain-Barré treatment until we had the SID-GBS trial. So the purpose of this study was to evaluate whether a second dose of IVIG, also referred to as SID, is effective in patients with Guillain-Barré syndrome, particularly those with a predicted poor prognosis. So this study was conducted at 59 centers in the Netherlands between 2010 and 2018, and it was the first double-blind randomized control trial that we have on this topic. They included patients from the first dose of IVIG, which was given as 2 grams per kilogram over 5 days. And then on day 7, after the first dose, those with poor prognosis were then randomized to another round of IVIG or volume-matched placebo with albumin. And patients were followed up at periods of 4, 8, 12, and 26 weeks. So in order to predict prognosis, they used the Modified Erasmus GBS Outcome Score, or MIGOS, which is a validated tool used to predict prognosis in these patients. And scores of 6 or higher are associated with a poor prognosis. So these patients have scores with 6 or higher have an 85% probability of not walking independently at 4 weeks and 35% probability of not walking unassisted at 6 months. This score also uses the MRC sum score, which I just want to touch on briefly. So this measures weakness and it ranges from 0 to 60. And it's just separated by different muscle groups, and it's inversely used inversely on this scale. So higher MRC scores equal more functioning, higher functioning. Factors that predict poor prognosis in Guillain-Barré include late age of onset, preceding diarrhea or Campylobacter infection, the need for ventilator support within 1 week of symptom onset, as well as severe weakness measured with that MRC sum score. So patients were included if they were 12 years or older and received the first round of treatment within 2 weeks of their symptom onset. and included patients also had a MECO score of 6 or higher. Patients were excluded if they had a known severe reaction to blood or blood products in the past, or if they were pregnant or had severe comorbid conditions, which the authors defined as malignancy, severe cardiovascular disease, AIDS, or severe COPD. Patients were also excluded if they were on immunosuppressive therapy within the past month, including corticosteroids equivalent to more than 20 milligrams of prednisone daily. The primary outcome of the study was improvement in the Guillain-Barré Disability Scale score by at least 1 point at a period of 4 weeks. So I think of the scale as being similar to the modified Rankin score, but tailored to Guillain-Barré patients, where 0 is healthy and no deficits, and 5 is weakness so severe that the patient requires assisted ventilation. And the scores in between represent varying degrees of independence with respect to walking and running. There were a variety of secondary endpoints, including the same disability score at periods of 8, 12, and 26 weeks, as well as mechanical ventilation characteristics, ICU and hospital lengths of stay, as well as serious adverse events. So overall, 93 patients were included, 49 in the treatment group and 44 in placebo. The majority of these patients were male, which is consistent with how the disease state normally presents, as well as a Guillain-Barré disability score of 4 at baseline and a demyelinating disease type. Baseline characteristics statistics were not reported, but some observations include that patients were slightly older in the treatment group at 66 versus 59 in the placebo. And this may seem insignificant, but age greater than 60 automatically scores 2 points on the MECO score versus 1 point for the placebo group. There was also a higher percent of Campylobacter infection and diarrhea in the 4 weeks prior to randomization in the treatment group. So overall, 37% of patients in the treatment group did experience the primary outcome of a Guillain-Barré scale improvement score, improvement by 1 point or more at 4 weeks versus 27% in the placebo group. And this difference was not significant. And you can see here that most patients started at a disability score of 4 and ended at 4. None of the secondary outcomes were significant either. However, I do want to point out that more patients required mechanical ventilation in the treatment group, and this is presumably after treatment was initiated, although it wasn't, the time point at which they were intubated wasn't well defined. Also, the median duration of mechanical ventilation was 26 days in the treatment group versus 43 days in placebo, but unfortunately statistics were not reported on this outcome, and it didn't really seem to translate into shorter lengths of stay, as those were similar between the two groups. A variety of subgroup analyses were run to see if any one particular subgroup of patients based on baseline characteristics might benefit from a second dose, but none of these were significant either. Patients in the treatment group did experience significantly higher rates of serious adverse events. And I do want to point out that statistics were only reported on overall events, but patients in the treatment group did have more thromboembolic events, and mortality was 4 in the treatment group versus 0 in placebo. The authors concluded that only 1 of these 4 deaths could potentially be attributed to the second dose of IVIG. So overall, the authors concluded that there was no benefit and a potential for increased risks of treatment with a second round of IVIG. Therefore, it should not be considered in patients with a poor prognosis who don't respond to initial treatment. Some strengths of this study are that it's the most robust data we have to date, and it's the first and largest randomized controlled trial we have on this topic. I also felt that the inclusion and exclusion criteria ensured careful selection of patients who might benefit most from a second dose of IVIG. Additionally, I feel that the time points they selected for follow-up were appropriate based on typical disease progression, as well as response times to IVIG and time points used in previous literature. And last but not least, their results were also supported by the 2020 prospective observational study, as well as other studies in Guillain-Barré that looked at giving additional immunotherapies, whether that was 6 versus 4 cycles of Plex or giving IVIG after Plex, both of which have been shown not to be beneficial. Some limitations were that patients tended to be older and had Campylobacter and preceding diarrhea more commonly in the treatment group, as I've stated. So this translates to a baseline score, MIGO score of 9 in the treatment group versus 7 in the placebo group, where 6 or higher is regarded as poor. However, patients in the treatment group didn't seem to be worse off at any of the designated time points in the study. Mechanical ventilation was also not well described, including the time points at which patients required intubation, as well as the lack of statistics on the duration of mechanical ventilation. The authors also didn't really discuss these endpoints much in the article or in the supplementary material. However, all that being said, I do believe that's still an important outcome, but it didn't seem to translate into decreased ICU length of stay or decreased hospital length of stay overall. Lastly, given what we discussed regarding a potentially increased number of patients with worse prognosis in the treatment group, the possibility exists that some of these adverse events could have been related to the disease course itself and not necessarily the drug. However, there is increasing amounts of data to suggest a link between IVIG and thromboembolism. So in general, I agree with the author's conclusion that a second dose of IVIG should not be considered, except in patients with treatment-related fluctuations. And this can be seen particularly with patients who have CIDP or chronic inflammatory demyelinating polyneuropathy. This can present very similar to Guillain-Barré, but some differences include that it continues to progress or a patient has relapses for periods of 8 weeks or more. The onset is usually less clear than in Guillain-Barré, and antecedent events like infection are far less common. Patients with CIDP also less frequently have respiratory involvement. So if you see a patient whose time course seems a little off and they improved with an initial round of IVIG, but then the disease progressed after that dose wore off, then I would consider redosing. Unfortunately, at this time, the question of what to do if someone fails to improve with IVIG or Plex remains unanswered. You could consider Plex after the first IVIG, but keeping in mind that it will remove the IVIG that you just gave unless you wait until 14 days or so, at which point it may be futile. And to my knowledge, this hasn't been studied, but we do know that data doesn't support giving IVIG after a patient fails Plex. There is some data in multiple sclerosis that suggests immunoadsorption, so that practice I had mentioned in Germany may have better outcomes than Plex, but again, it's not available in the US at this time. So just some future directions. Eculizumab or Soliris has been studied. The results haven't been published yet in a phase 2 trial in Japan for patients with Guillain-Barré. Complement inhibition, which is a phase 1 trial that's ongoing, as well as IgG degrading enzymes with a drug called inflammasase, is in a phase 2 trial at the moment. So all of these aforementioned studies are in patients with an initial GBS disability scale score of 3 or more. So these are all in patients with more severe disease. So just some things to look out for. And I thank you all for listening, and I would be happy to answer any questions you might have.
Well, thank you for your presentation and the review about Guillain-Barré syndrome and therapies and future directions. I guess to your question about patients fail the first therapy, does your institution have any specific criteria in which they would recommend using a second dose for IVIG?
To my knowledge, To my knowledge, there's no hard and fast criteria. It's more of just discussion between providers and taking into account of whether or not it could be CIDP. So usually if it's acute CIDP, we don't necessarily know it's CIDP at that time. So just kind of discussing the differential with the providers and seeing if they did have any benefit with that initial IVIG dose, and then considering repeating it if there was some benefit that was seen and wore off.
There's also a notion that you need to give therapies or IVIG as soon as possible and early in the course of disease prior to the complete damage of the nerve fibers. Do you have specific recommendations, or the authors chose like 7 to 9 days in their study to administer the second dose? Is there any other recommendation about how soon you should think about giving another dose?
Yeah, so based on what I had seen, most patients will respond within a few days. However, that can be highly variable, but the effect should be seen within, at least some positive effect should be seen within 1 week. So I do think that's appropriate, an appropriate time point to reassess. Did you have a second part of your question?
No, so there really is there's no guidance about when to give the second dose, but there's a notion that you always try to give it as soon as possible.
Correct.
Especially the first dose. We have a question in the chat. What about patients who failed IVIG following PLEX? Would there be a role of another course of IVIG therapy, given that PLEX may have cleared some of the IVIG?
That's a good question, and that kind of ties into your point of, so it's already been probably at this point at least a week. So if IVIG has been given and then PLEX, that's probably at least 10 days. So that nerve damage may be irreversible. So if there was no response seen with that initial dose of IVIG that was given sooner, I personally don't think there's really a role in trying it again. I think if they were going to respond, that they would have responded to that initial dose.
I guess we have time for one more question. So for the patients in the placebo arm, did the authors comment on any other therapies they received? Did they receive PLEX or steroids?
That's a good question. They didn't comment a lot on it, but patients were allowed to receive methylprednisolone in addition to either placebo or IVIG. They didn't really report the numbers of how many patients received the steroids, though. And patients were not allowed to get PLEX while they were doing this study.
Or I guess we are out of time. Thank you so much for presenting on this controversial topic, and thank you for the moderators that joined us, as well as the two presenters. There will be another donor club coming soon. It's in December of this year, so hopefully we can see you then. Thank you, everyone.